So let's define glomerular filtration rate. This is the rate at which plasma is filtered into Bowman's capsule. The units here are in milliliters per minute or liters per day. In a young healthy adult, normal GFR is about 120 milliliters per minute or 180 liters per day. That's a number that you need to know for the exam. There are 4 factors determining GFR. The net filtration pressures. By far and away, the hydrostatic pressures of glomerular capillaries is the most important factor. So if there's an increase in the hydrostatic pressure of the glomerular capillaries, there's an increase in GFR. If there's a decrease in the hydrostatic pressure of the glomerular capillaries, there's a decrease in GFR. That's the most important factor. The oncotic pressure of the glomerular capillaries also plays a role. Oncotic pressure opposes GFR, so if there's an increase in oncotic pressure, there is a decrease in GFR. If there's a decrease in oncotic pressure, there's an increase in GFR. For example, if somebody has a nephrotic syndrome, in the nephrotic syndrome, there's a loss of albumin, there's a decrease in the oncotic pressure, and that actually leads to an increase in GFR. So if they ask you, somebody with a nephrotic syndrome who has a decrease in the oncotic pressure, they actually have an increase in GFR. Now, the hydrostatic pressure in Bowman's space opposes GFR. This normally plays a minor role, but in some situations, like for example renal stones or in men with benign prostatic hypertrophy, this pressure rises and that will oppose GFR, and that can lead to a decrease in GFR. Protein or oncotic pressure in Bowman's capsule is usually very low and usually does not play a role. That's usually 0. So oncotic pressure, the oncotic pressure in the capillaries will keep fluid in the capillaries. So in a nephrotic syndrome, there is a loss of protein through the kidneys, leading to a decrease in the concentration of albumin and other proteins, and that leads to a decrease in the oncotic pressure in the capillaries. That leads to an increase in filtration, and that will lead to edema formation. And this is why patients with a nephrotic syndrome present with edema formation, because they have an increase in microfiltration, and that means that fluid will leave the capillaries and filter into the interstitial space, and that will lead to pitting edema. And this is why patients with the nephrotic syndrome will present to us with edema. So this slide just summarizes the net filtration pressures. Once again, the glomerular capillary hydrostatic pressure is the most important pressure in determining GFR. And we said that the oncotic pressure will oppose GFR. And again, if there is a decrease in oncotic pressure, there is an increase in GFR. And if there is an increase in oncotic pressure, there is a decrease in GFR. So these are some normal values. These are the values of your Starling forces in the glomerular capillaries. So you have the glomerular capillary hydrostatic pressure, which is actually quite high. It's 45 millimeters of mercury. And that is a very high hydrostatic pressure, and that is the force favoring filtration. So that hydrostatic pressure will push plasma out of the glomerular capillaries. Then you have the glomerular capillary oncotic pressure, which you can see on the slide is 24. The oncotic pressure is a force that opposes filtration. It's a force that favors reabsorption. In a patient with a nephrotic syndrome, the glomerular capillary hydrostatic pressure would be lower than 24. Let's say, for example, 10. And that will actually favor filtration. Therefore, in the nephrotic syndrome, when you have a lower glomerular capillary hydrostatic pressure, you actually have an increase in GFR, or an increase in filtration pressures. Out in the periphery, if you look at your peripheral capillaries, in a patient with a nephrotic syndrome, those patients will have a low oncotic pressure in the peripheral capillaries, and that will favor filtration out in the periphery, and that's why you get edema formation in the nephrotic syndrome, because there's a low oncotic pressure. But here in the glomeruli, they actually will favor GFR. On the top of the slide, you have Bowman's space. hydrostatic pressure, which is usually very low, around 8. So if that increases, that will also oppose GFR. So classic examples you will see in the exam is patients with post-renal azotemia. For example, somebody with renal stones. In renal stones, you will have an increase in Bowman's space hydrostatic pressure, and that pressure will oppose GFR, and that will cause renal failure. Another great example is BPH. In BPH, there will also be an increase in Bowman's space hydrostatic pressure, and that will oppose GFR, and that will cause renal failure. Then you have Bowman's space oncotic pressure, which is normally 0 because proteins are not filtered. That number does not contribute. So if you look at your net filtration pressures, you see the net filtration pressures favor filtration, and this is why you have filtration at the glomerular capillaries. One important job of the kidneys is to preserve volume. Let's give you a clinical correlation. Say a patient has diarrhea or vomiting, and I mean profuse diarrhea or vomiting, severe vomiting, or hemorrhaging. You will lose volume. The kidneys preserve volume in this situation. They preserve extracellular volume. How do they do that? One important way to preserve volume is to increase reabsorption of fluid and electrolytes in the proximal tubules. Let's look at how they do that now. How do the kidneys preserve volume? Well, in vomiting, diarrhea, or in patients that are on diuretics, for example, hydrochlorothiazide, they lose volume. They're in a low volume state, decrease in their intravascular volume. Well, when you have a decrease in intravascular volume, that actually increases your intravascular albumin concentration. It increases the concentration of albumin in your intravascular space. And your albumin concentration gives you your oncotic pressure. So in a low volume state, this increases the concentration of albumin. This leads to an increase in your oncotic pressure. And remember, it is the oncotic pressure that determines the reabsorption in the proximal tubule. So when you increase the oncotic pressure, you increase reabsorption of sodium and water in the proximal tubules. And that will lead to an increase in your intravascular volume. It leads to decrease in excretion rate of sodium because you are excreting less sodium, and that leads to increased reabsorption of that volume, and that increases the intravascular volume. So this is one way that the kidneys will preserve volume in a low volume state, by increasing reabsorption of solutes and water in the proximal tubules due to increasing the oncotic pressure. So again, in low volume states, you will have an increase in reabsorption of solutes and water in the proximal tubules. So let me give you a clinical correlation. In patients with nephrogenic diabetes insipidus, the problem is the ADH receptors in the collecting duct are not functioning. They do not respond to ADH. It is impossible to increase reabsorption of free water in the collecting ducts. This leads to hypernatremia, very high serum sodiums. And no matter what, you cannot get those sodiums down. You can give the patient free water, and the patient will urinate out that free water. So how do we treat these patients? What do we do for these patients? The treatment of nephrogenic diabetes insipidus is a thiazide diuretic. That's how we treat nephrogenic diabetes insipidus. Here's how it works. The thiazide diuretic will inhibit reabsorption of sodium chloride in the distal convoluted tubules. That will have several effects here. One important effect is it will increase the excretion rate of sodium. You will excrete more sodium, and that will help you get rid of sodium and decrease your serum sodium. But another important effect here is it will decrease your intravascular volume, and that will lead to an increase in your albumin concentration, which will increase your peritubular oncotic pressure, which will lead to an increase in reabsorption of free water. So in this situation, you're not able to increase reabsorption in the collecting ducts. You simply cannot do it because ADH receptors are not functioning. But you can increase reabsorption of free water in the proximal tubules. And you do by dehydrating the patient, by decreasing the intravascular volume, leading to an increase in your peritubular oncotic pressure, and that increases reabsorption of free water in the proximal tubules. And that increase in reabsorption of free water will dilute out your serum sodium, and that gets your serum sodium levels back down, and that corrects the hypernatremia. And this works. I've seen this work. I've had patients who comes in with what? How do you get nephrogenic diabetes insipidus? This is another common question. Well, this lady overdosed on lithium. She had lithium overdose. Her serum sodium went up to 175. We could not get the serum sodium down. We gave her a thiazide diuretic, and it worked. It works, and this is the mechanism of action. This is how it works. This is how thiazide diuretics correct hypernatremia and nephrogenic diabetes insipidus. Here's another great clinical correlation for you. Why do patients with primary hyperaldosteronism, also known as Conn syndrome, not have edema? Well, the answer is the kidneys come to the rescue. One of the functions of the kidneys is to maintain normal volume status. That means in a high volume state, the kidneys will keep you euvolemic. And here's a perfect example. So at steady states, patients with primary hyperaldosteronism actually have normal excretion rate of sodium. They only have a mild increase in intravascular volume, just enough to give them hypertension. This is due to a concept known as escape from aldosteronism. The serum sodium in these patients is normal, normal, normal. They do not have hypernatremia. It's an important concept to understand in primary hyperaldosteronism. So at steady state, they have a normal excretion rate of sodium, and they actually have a normal intravascular volume. They're actually not hypervolemic due to the kidneys correcting their volume status. Why do patients with SIADH not have edema? Same concept, except this time we're dealing with free water. These are situations where the body originally has a high volume state, but the kidneys come to the rescue to make you euvolemic, and you do not see edema in these patients. So the next slide, we'll talk about how this happens. So escape from aldosterone. What does this mean? Does aldosterone dress up in a yellow jumpsuit and escape from prison? No, that's not what I mean. This is how it works. Here's how the story starts. In Conn syndrome, or primary hyperaldosteronism, what you have is usually an adenoma or could be hyperplasia of the adrenal cortex that is secreting high levels of aldosterone. That's primary hyperaldosteronism, leading to hypokalemia. Metabolic alkalosis, we'll come back to this later, and you do get hypertension. Why? Because aldosterone leads to increased reabsorption of sodium and water together, increased secretion of potassium leading to hypokalemia, increased secretion of protons, and we'll come back to this a little bit later, and you do get hypertension due to the sodium and water retention. You do not see hypernatremia because as you pull sodium, you pull water with it. So what you do see here is an increase in your total body sodium. You do see an increase in your total body sodium leading to hypertension, but you do not see hypernatremia, meaning you do not see an increase in your sodium concentration. Remember, when you talk about concentration, let's take a cup of water, for example. That cup of water and sodium has sodium and water. There's a certain concentration. If I add the same amount of sodium and water, I'm not increasing the concentration of sodium, but I'm increasing the total amount of sodium in there. So in this situation, I'm increasing my total body sodium, so I may have an increase in my total body sodium, but I'm not increasing my sodium concentration because I'm increasing equal amount of water retention with aldosterone. And that's an important point. You will not see hypernatremia with hyperaldosteronism. So this increase in sodium and water retention will give me initially increase in my intravascular volume. What will that do? Well, this will lead to an increase in ANP, atrial natriuretic peptide secretion from the right atrium. Anytime you have stretch on the right atrium, you get an increase in atrial natriuretic peptide. Now, you also will get stretch on the ventricle, and that will lead to an increase in BNP. BNP is clinically useful because we use BNP to diagnose congestive heart failure. Anybody that comes in with shortness of breath and we're not sure if they have congestive heart failure, we check BNP. If that's elevated, that tells us that they have congestive heart failure. Now, ANP is secreted from the right atrium. What does ANP do? ANP uses the second messenger cyclic GMP to vasodilate the afferent arterioles, vasoconstrict the efferent arterioles. It also suppresses renin release. The net effect here is to increase GFR. Also, when you increase your intravascular volume, this has a diluting effect. You dilute your intravascular albumin concentration. This dilutes your oncotic pressure, or this leads to a decrease in your oncotic pressure. This leads to a decrease in your oncotic pressure. When you decrease the oncotic pressure, this leads to a decrease in the proximal tubule reabsorption of sodium and water. The net effect of increasing GFR and decreasing proximal tubule reabsorption is to increase the filtered load and increase the excretion rate of sodium. This gets you back to a normal excretion rate of sodium. So initially, you do have a decrease in the excretion rate of sodium when the story starts, but at steady state levels, due to the increase in ANP leading to an increase in GFR, and due to the decrease in proximal tubule reabsorption of sodium, you get an increase in your excretion rate of sodium back up to normal. So if they ask you on step 1, in a patient with Conn syndrome, you're going to see a normal excretion rate of sodium due to sodium escape. You're going to see a normal intravascular volume. So the net effect here is to have an increase in natriuresis and an increase in diuresis. And that's what ANP does. ANP gives you an increase in natriuresis and an increase in diuresis. And that gets your intravascular volume back down to normal. So once again, normal excretion rate of sodium, normal intravascular volume, no edema formation. So what are you not going to see? No edema, no JVD, no pulmonary edema, no crackles. These patients are what we call euvolemic. When you do a physical exam, they're not going to have findings of hypervolemia. They're going to be euvolemic due to this effect. Now, in patients with SIADH, all the same concept, except this is going to be with free water. ADH leads to increased reabsorption of free water. That will lead to hyponatremia, and your patients will have hyponatremia, but they will not have edema. They will not have ascites. They will not have JVD. Once again, an SADH, they will be euvolemic. That's because an SADH, they will have volume expansion. They will increase in intravascular volume, leading to an increase in ANP. ANP will increase GFR. ANP will lead to increase in natriuresis and diuresis, and that will get their intravascular volume back to normal. They will have a normal intravascular volume. They will not have edema formation. Same concept, except with free water. And this is what the kidneys do. They maintain normal volume status in the setting of high volume states. And that's why these patients are euvolemic. So the next topic is membrane permeability. So you have a large surface area for filtration, and the membrane is permeable to water as well as dissolved solutes. The passage of large proteins is restricted because of a negatively charged membrane of the glomerular basement membrane, not due to a size restriction. So your plasma proteins have a negative charge, and the glomerular basement membrane is made up of a matrix of negatively charged proteins, and these negative charges repel each other. So the reason why proteins are not normally filtered is due to these negative charges repelling each other, not a size restriction. So in addition to the net hydrotic force, GFR depends on both permeability and surface area of the filtering membrane. Decreased GFR in most disease states is due to a reduction in the membrane surface area. Also, due to a decrease in the number of functioning nephrons. Materials that are freely filtered at the glomeruli include major electrolytes like sodium, chloride, potassium, bicarb. Your waste products such as urea, creatinine, your metabolites, glucose, amino acids, and your acids such as ketone bodies, phosphates, another important substance that is freely filtered. Non-natural substances that we inject in patients to do experiments, which we're going to talk about later in this lecture, which include inulin and PAH, and some low-weight proteins and peptides such as insulin and myoglobin. Some substances that are not freely filtered include albumin and other plasma proteins, lipid-soluble substances that are transported in plasma attached to proteins, which include your lipid-soluble bilirubins, thyroid hormone, and unbound lipid-soluble substances such as cortisol. As blood flows through the glomerular capillaries, plasma is filtered, but albumin is not. Therefore, as you're filtering, your plasma albumin concentration increases, therefore the oncotic pressure increases. This oncotic pressure becomes the oncotic pressure in the peritubular capillaries, and remember, this is the oncotic pressure that drives reabsorption in the peritubular capillaries, and that's an important point to remember. So remember, the nephrotic syndrome is caused by disruption of the filtering membrane. You lose the glomerular basement membrane, you lose that negative charge, and now your plasma proteins are able to filter. They pass through the membrane, they're eliminated in the urine, and now you lose your oncotic pressure, and that's why you get edema formation. This is associated with non-inflammatory injury to the glomerular basement membrane system. So the nephrotic syndrome, you have marked proteinuria defined by proteinuria over 3.5 grams per day. That's the definition of nephrotic syndrome. And again, this is due to loss of the glomerular basement membrane. Edema formation due to loss of the oncotic pressure. Low serum albumin. Lipiduria. Now this is very important, and this is a high yield concept that's commonly tested on step 1. You will see a high serum LDL. This is due to increased lipid synthesis in the liver. The liver produces albumin, and in a setting of low serum albumin, the lipid will be producing extra albumin to try and replace the albumin that is lost. As a byproduct, the liver will produce high LDL. So these patients will present with very high LDLs, 200, 300, and this must be addressed, and these patients must be treated with statins because they're at high risk for atherosclerosis and coronary artery disease. So this is a high yield concept that they like to go after on the exam, and you should remember this. These patients also have a hypercoagulable state due to loss of antithrombin 3 because this is a lightweight protein, and this is lost before your clotting factors are lost. So they're also hypercoagulable and high risk for developing DVT and pulmonary embolism. So these are important points to remember about the nephrotic syndrome. Now, the most common cause of nephrotic syndrome is diabetic nephropathy. The pathophysiology of diabetic nephropathy starts with non-enzymatic glycosylation of the efferent arterioles as well as the glomerular basement membranes. This leads to hyaline arteriolosclerosis of the efferent arterioles. This leads to narrowing of the efferent arterioles, leading to hyperfiltration pressures at the level of the glomeruli. This leads to the nephrotic syndrome and eventually leading to Kimmel-Steele-Wilson glomerulosclerosis, and that's what you would see on the biopsy. So this is the pathophysiology of diabetic nephropathy. If they give you a patient with nephrotic syndrome with HIV, heroin abuse, obesity, or sickle cell, the answer is they have focal segmental glomerulosclerosis. You'll get some of these biopsies in the path section. If they give you a child with nephrotic syndrome, they have minimal change disease, effacement of the podocytes, and they respond to steroids. If step 1 gives you a patient with nephrotic syndrome and they give you IgG4 to phospholipase A2 receptor, that could be a patient with membranous glomerulonephritis. Or, this is particularly high yield, if the patient has a solid tumor, or more likely they'll give you an elderly patient over 65 who's diagnosed with membranous glomerulonephritis, and they will say, what's the next step? The next step is to search for a solid tumor. Look for colon or lung cancer. Do what we call a malignancy workup. Also, look for hepatitis B or hepatitis C. SLE can also be associated with membranous glomerulonephritis. Certain infections like syphilis, malaria, or hepatitis B or C, as we said, can be associated with membranous glomerulonephritis, and certain drugs like NSAIDs, penicillamide, captopril, probenecid can also cause membranous glomerulonephritis. If they give you a patient with nephrotic syndrome with enlarged kidneys, liver, and restrictive cardiomyopathy with hypopituitarism, think of amyloidosis, and you would do a fat pad biopsy, staining for Congo red, and look for apple green birefringence under polarized light. And these are the causes of the nephrotic syndrome. Nephritic syndrome. In the nephritic syndrome, there is an inflammation of the glomerular membrane. This disruption allows protein, but mostly red blood cells, to cross the filtering membrane. In the nephritic syndrome, there will be some protein, but not nephrotic range proteinuria. There will be hematuria, so mostly the presentation is blood. There may be oliguria. There will be hypertension due to the kidney's loss of ability to regulate volume. Now you're going to have sodium retention. So when the kidneys lose the ability to retain volume, you develop hypertension. You will see azotemia due to inability to filter and excrete urea.